is going to help me do this prone lateral. And so we just to save time, we've placed a retractor, and we're doing, I think this is about L2, and we've placed the retractor on the 50-yard line. And as you can see here, the nice thing about going prone lateral is you basically are doing a lateral procedure, but in a prone position. So the abdominal contents are going down. You're a little bit more anterior to the plexus because the hips are extended, and in terms of positioning, it can be a little bit uncomfortable. But what do you think, Zach?
Pretty good thus far.
So, and again, we're basically, the key to, I think, to doing this procedure is you have to position appropriately and make sure that you can get good fluoro and good C-arm, and Shelly here is doing a great job. So can you guys see that, Jens? So we have a nice lateral, and we're over the vertebral body. So we're going to try to do a corpectomy. And just like corpectomy that we would do in a lateral position, the very first thing that we do, and Zach's going to demonstrate this, is we're going to do a discectomy of the disc above and below the vertebral body that we're going to take. So Zach, go ahead and put we use a little box cutter to place it into right over the disc space. And then once we put the box cutter in, we'll get an x-ray. So you can see we need to move it a little bit more south.
I'm right at the.
And again, our incision is very small. So if you can see, that's not bad there.
Yeah.
Zach. So let's see.
One more shot. It's better.
Yeah, that's good. Okay, so I'm going to mallet this in. And so usually I use a box cutter to go posterior, take the posterior third of the disc and then turn around and, let me get it on this side, and then do the exact same thing going the other direction. Do we have some suction as well? I think that's moving a little bit. Shot there? Okay, there we go, Zach. Go ahead and mallet that. And then shot there. Okay, so.
It's not really going.
Yeah, so what we'll do is, let me see, do we have let me see a shim shot there. Sometimes we put a little shim in to keep the posterior blade from moving. So we're going to go ahead and do that. Let's see here. And then do we have a little osteotome or a cob? Let's see.
Not quite.
Yeah, it's not quite lining up. It's not going in. That's fine. We'll just use a cob to get in. So I think it's going to be something like that, Zach. So let's get a shot there. Okay, that's pretty good.
With the cob.
So yep, just going with the cob. Sometimes with a little box cutter, the osteophyte can get in the way. So we're going to go ahead and.
That's good.
Does that feel like you're in the disc space?
Yeah.
Great. So go all the way across. And then okay. And then we're going to try one more time to get the. There we go. Get the. Go ahead and mount that in, Zach. Okay, so now we're putting in the posterior shim in, so that way we can keep the posterior blade from moving. And then Zach just got in the disc space, and let's see the box cutter back.
Oh, I got it right here.
Okay, so now what we're going to do is finish our discectomy, and then, so Zach, do you see your discectomy hole there? So try to get it right in there.
Yeah,
Sorry.
I got you.
And the other nice thing about it, I think, when you're going prone,
Give that mallet. Thank you.
basically you don't have to reposition and go. Let's get a shot there. And go from lateral to prone. Here, let me help you there, Zach. Just kind of slide it up a little bit. Okay. Let's get a shot there, Shelly. That's better. Okay. So now try going there.
Hey, Rod, can I ask you a question whilst you're doing this?
Sure.
Can you hammer and talk?
Shot there. There we go. Go all the way across. Go ahead.
How good would your visualization of the dural sac be if you did a corpectomy?
How do you repair it?
No. How would you see the dural sac in that prone position?
Oh, that's an excellent question. I think it would be nearly impossible to see it. You'd have to airplane the bed a little bit. So actually, let's do that. Let's go ahead. So,
One more.
There we go. You got it, Zach.
I think I'm hitting body.
And then let's see the suction, Tyler. So what we're gonna do, actually, Shelly, let's do an AP. Sometimes it's easier.
I got it.
Did you get it?
Shot.
Come on out for a sec.
Kind of in the body.
Yeah, so sometimes it's easier because this is actually good demonstration. The fluoro can sometimes get in the way. So what we're gonna do is, Shelly, why don't you come around and then we'll get this handle off. And then let me see the cob. Okay. Great, I'll take the cob back.
So Rod, I definitely like this technique in a setting of corpectomy for trauma. I feel a little bit insecure about doing a corpectomy with a lateral plate, but I've seen that done. Do you recommend that for fixation, or do you want to do a posterior supplementation as well?
Oh, sorry, Amir, the volume in here isn't great. So I think what you said was, do we always go posterior? And the answer is yes. So we went nicely across on there. So we're almost done with our discectomy. Get a shot there, Shelly. So you can see we're in the disc space. One more shot. Great. And then, okay, shot there. Okay, and then so there's our disc space there. And then you can see just from the, on the AP, Shelly, let's go ahead and come back to a lateral. Actually, no, just bring the height up. Yeah, is it up all the way? Okay, that's fine. Shot there. So now let's go ahead and, so Zach, let's go. Do we have a larger cob? So sometimes we just stick with the cob. So just go ahead and put it in the same disc space. And then do we have a cage already preloaded? This one will probably be, 35 is good. And then just go all the way down the bottom. So we're using the Globus system here.
Hey guys, is there any way we can look down the cannula better? Can we look down into the aperture of that cage?
Yeah, I wish, we were just talking about that. And we can, except for we'll have to probably get Shelly to come all the way around. And then we'll adjust the camera. So let's do one other thing before you go away. So Zach, let's go and get the disc space above. So you can see the disc space there, right?
Yeah.
So why don't you now use the box cutter? Do you have a smaller box cutter than that, or is that? Okay. And just like if you're doing, a corpectomy in the cervical spine, it's kind of painful, but you have to really spend extra time doing a thorough discectomy. It just makes the corpectomy go so much faster. And you saw John Hurlbert did a really nice open corpectomy T12 at L3. The plexus, L2 and L3, the plexus, it really isn't as much of an issue.
Shot.
Perfect. Okay, so now Zach feels pretty good now. He's in the disc space. And then let's go. That's perfect. Okay, so how far in are you, Zach? Go a little bit more. So typically, again, in the lumbar spine, you can, what's great about the CT scans nowadays, come around and then we'll see if we can get a shot, Tyler, of you can pretty much measure everything before, and typically for the lumbar spine, it's usually about, at L3, I'd say it's anywhere from 45 to 50 millimeters is the length of the end plates. And so we pre-assemble the cage based on the measurements on the CT scan. Let's get a shot there now, Shelley. So we're across the disc space, and then what we're gonna do is, so go ahead and take it out now. And you can see, again, you normally can turn it, but on this particular box cutter, I know it's about 50 millimeters from one end to the other end, and then the aperture is about 45. So I think we can load. Do you have 45? Okay, that's fine. We'll go with 40. Annika's assisting here with Christian. So, yep.
Is there a way to get this?
Yeah, I think it's on, isn't it? So
the handle just keeps slipping in.
It slides off.
So, Rod, would you feel like doing a lateral corpectomy at L4 would be a contraindication, or do you just kind of try it and see what the plexus gives you?
Honestly, that's a great question, Amir. It's probably the most challenging level to do it at. So it's really dependent on the plexus. Go ahead, Zach.
Shot.
And usually what I do, actually, I will go and find it and then put my retractor right in front of it. In fact, Jens and I just did one, and that's exactly what I ended up doing. Let's get a shot there. I went ahead and mapped it, and then placed my retractor right in front of it. And that's really, when you're doing lateral surgery, that's the only thing that really gets me tense is if I'm doing a case and I can't, the nerve monitoring isn't really telling me where the plexus is, or I can't find it, or everything's green and nothing's lighting up. That's when I get kind of nervous and don't really trust the nerve monitoring shot there. Okay, so now we're almost all the way across. Okay, so now let's see can you guys see it all, Jens? So
okay,
it's not a bad.
Can you focus in the depth? Right now we're focused too shallow, so if you can zoom,
trying to suck all the,
get the focal depth established.
Yeah.
And so just to orient us, you just took your instrument out of the caudal
Rostral.
space?
rostral. So this is
Rostral.
rostral, and then this one is caudal over here. And then let's see so come back around, Shelley. And then let's see the other box cutter.
Did you see the vertebral artery? Segmental artery?
The vertebral artery,
I think that's the
we have
lumbar
not seen
plexus.
because we're in the lumbar spine. But I can see the retractor is trying to have us move anterior. And this is one of the big issues with doing prone lateral, is that it tends to push you down and out, and you're aiming, by the time you're done, you're aiming towards the vena cava or the iliac veins, depending on where you're at. Let's get a shot there. And that's beautiful, Zach. So the vascular structures, obviously in lateral surgery and prone are can be an issue. And so something like that. Shot there. There you go. And then hold on 1 second, Zach. Let's see. One more shot. Yep, shot again. And then let's see, shot there. Okay, that's pretty good.
Yeah.
And then once we so we did the discectomy that was more caudal. Now we're doing the discectomy more rostral. And then once we do the discectomy, it's pretty much just making the cuts in the vertebral body and you're done. Okay, so now come back around. Again, and you can see the little holes, the apertures in the box cutter, and typically, a corpectomy, again, when you're doing lateral procedures or prone lateral, will take anywhere from an hour to an hour and a half, and you probably spend about 2.5 hours getting the patient positioned, and then and making sure you can get good X-rays. So we spend a lot of time. Yeah, go ahead and take that out. We spend a lot of time getting everything set up, and you guys didn't see that, but we had to spend a lot of time trying to tape the patient down, getting good AP lateral X-rays, and then
You have a small
making the incision so that it's right over the
We'll just
level
pull
that
it
we're
out.
going to go.
Have
And I
the
wish
handle?
you could see the incision. It's so tiny. But the retractor placement is so important because that's where you're going to do wherever you're. So now let's see. Do we have a osteotome or a cob? Wherever your retractor is, this is exactly where your cage is going to end up. So if you have a retractor that's not optimally placed, now's the time to change it. So we can do that, Zach. So let's take a look. See if we're happy with the retractor placement. Shot there?
I think it looks pretty good.
Okay. So that looks good from this view. And then, Shelly, let's get one more view from a lateral approach. Can you guys see there inside or not really?
Pretty good, yeah.
Okay. So so you can see the blade is on the posterior vertebral body, right, Zach?
Mhm.
Can you see that nicely? And then
Yes.
again, we probably can rotate the retractor a little bit, so you can see. So look, the top blade, we can probably rotate just a tiny bit. So Christian, if you can just hold on, if you can loosen the arm. So we're going to show you guys really quick, and then yeah, just go ahead and loosen it. So okay, so now let's go ahead and get a shot there. So that's a little bit better. Okay, and then shot there. Okay, so shot there. Okay, let's go ahead and tighten that. And then Shelly, let's get one more shot. Okay, so now we've got the vertebral body kind of isolated, and then Zach's going to go ahead and make his cuts. So go ahead, Zach. So we'll make, usually it's 2 cuts posteriorly, and then superiorly and inferiorly, and then hopefully we'll be able to just take it out in one piece. And then we'll have our shot. That's great, Zach.
So if you guys switch to a AP view,
Yeah.
that might let Zach have a good look inside, and then we can also see with the camera.
Yeah, so that's exactly what we're going to do here. We'll go to the AP view. Great. So you're almost all the way across.
Shot.
Terrific. So now you went all the way across, and then let's get another shot when he comes out.
I don't even need 2 posterior cuts. Like just one, I think, in this one.
Is it? Did you get it? Okay, fine.
Take a look.
Yeah. Okay. Yeah. Okay. So now go ahead and let's do our other cuts. So now he's going to go
Interior.
anterior.
Shot.
Great, Zach. That's perfect. And we used to, I remember when I first started doing these, I used a drill, and it would take me like
Shot.
a couple hours to try to go all the way across. And I go millimeter by millimeter, but
It'll
it's
just pop out now.
so much easier. Great. We get some suction. And then do we have like what do we have for bony? Yeah, go ahead and grab it with the pituitary.
I think
don't know if you guys can see that, the opening there, but Zach's going to take out the vertebral body. And then we also have some slides that I sometimes use. Do we have those? Okay, great. And that kind of protects the end plate. Great. Awesome. Looks good, Zach. So keep taking more out. Do you need the cop still, Zach, or are you good?
Yeah.
Okay. Here we go.
Thank you.
So there's a couple more chunks left. A vertebral body looks like a little bit anterior, huh, Zach?
Yeah.
That's pretty typical. It's so much easier to get the posterior fragments out. And usually, when we've done these, Jens and Amir, I don't know if you guys, what your thoughts on, but I really like having, having done the posterior part first. Then you don't have to worry about taking out the, that's a great view of the.
Yeah.
It's really nice. Yeah, we can see it well.
And, it's nice. And then you can see, that's the psoas muscle. And we created a nice little plane. But I like it when, if you have to do corpectomy, is go posterior first, put in your screws, decompress the posterior wall. And then literally this part of the procedure, takes maybe an hour to do because you don't have, the back wall's already gone. All you're doing is finishing the corpectomy and dropping the cage in. And I think, Jens and I in the last 15 years, we've done a ton of these, and it's so nice because, especially in the lumbar spine, you can get a very large cage in and get good reconstruction of the anterior column. And the cages just keep getting better and better. How do you look there, Zach?
I think it looks pretty good.
You look good there? Okay, can you guys see that on the video?
Yes.
Do we have a pen field so I can show the team? So that's, oh, my hand's getting in the way. Okay, so you can see there's the cavity there. And then there's the ALL right underneath here. You can see them right in, and then you've got the vertebral body's gone. And then there's the end plate below, and there's the end plate above. And then let's see our slides. So I like using these slides, and basically what they do is they protect the end plates. So when we put the cage in, it kind of guides the cage so it doesn't go crazy. And sometimes actually keeps the cage from also going anterior as well, because you have a sense of the direction of where you're going to go. Shot there. It's not bad, actually. And it kind of distracts it open. Shot there. Okay, so, all right. So what I'll do, Zach, why don't I hold on, and then you get the cage, and then let's get one more shot there, Shelly. Okay, that's not bad. Sorry, it's taken so long to do the vertebrectomy.
That's going to be a bit big.
But
This is a small swing.
so this is the little trial. So we use the trial, and then do we have the? Yeah. Okay, great. Yeah, we'll just go ahead and. I don't know if you guys, maybe Zach will just show it to you guys. You don't need to put it in. Great, awesome. So yeah, so that's it.
Just the trial. That's the cage.
Yep, and then show everyone the cage, Zach.
I don't know what a slide is supposed to be.
So you can see the cage has been pre-assembled. Oh, sorry. Can you guys see that there?
Yeah, we can
So-
see.
We can see it.
Okay,
It's not
great.
focused.
And then now what we're going to do is go ahead and put it in. And again, I like these slides because they kind of give you a sense of the direction. Shot there. Keep that thing from going in. Yeah, we'll get it. Shot there. So, hold on 1 second, Zach. Okay, shot one more time. Okay, I'll hold on to this, and then you go ahead. Just make sure that you don't come out the front there.
Mm-hmm. Shot.
Great.
Shot. Hoppa.
So Zach is making it look really easy because he's on my service right now. So he's learning all the tricks and tips. I'm a little concerned that he's gonna steal all the IP here and run back to Canada. So we got to be careful. We can't teach Zach too much. Okay. So can you guys see that?
Yep.
So Zach did a beautiful job here, and right now I think it's the only thing left to do is get one more. Let's get one more shot. Are you happy with that, Zach? Maybe go in a little bit further. But
Shot.
that looks great.
Hey, Rod, it's John Hurlbert.
Yeah.
What have you ever disrupted the segmental on the other side, and how do you control it?
Okay, that's a great question. That's the very first thing I do, is I go down and find it and coagulate it. Because what'll happen is, like you pointed out, I mean, I think if you don't find it, my experience is that it'll just bleed like crazy, and it'll be really hard to like stop it from bleeding once you've gotten into it. One more shot.
I think the question was the contralateral segmental.
Oh, contralateral. Sorry about that. I couldn't hear that. Usually in my experience, we don't really, I honestly haven't had any issues with that, but that's a great thing to consider. You want to keep expanding, Zach?
Sure.
And then come back around, Shell. Yeah, we haven't really, I haven't had any issues with the contract. You would think it would be an issue.
You take a shot and we'll
So-
start expanding.
And then now Zach's going to go ahead and expand it.
I think for some of us that do these lateral procedures, the contralateral side is something to think about. I know in our M&M series, we've had contralateral radiculopathy, bowel injury, and ureter injury. So that's why you want to be really careful with those cobs going across.
Great. Okay. And then come back around. One more shot, and then we'll get the... Should we leave the retractor on so you guys can take it off? Or okay. So we're done. So sorry, we're kind of fast there, but I think, there's, I think, three main principles. So positioning, the plexus, and the placement of the retractor. Those are the most three important things. If you don't do a good job positioning, the case isn't going to go well. You're not going to be able to get to where you want. You have to find the plexus and map it out. And then retractor placement is key. As you can see here, you only have a small aperture that you can put this cage in. And if you put the retractor in the wrong place, it's going to go exactly where the retractor is.
Rod, can you go as low as, this actually looks really beautiful. Thanks for that camera angle. Can you go as low as L4? Can you do an L4 corpectomy with this?
Yeah. I mean, we did one together like 2 weeks ago, right?
No, I'm just asking for the audience's sake.
I mean, I think, again, I wouldn't start out by doing an L4 corpectomy. I probably would start at doing T12, L1, L2, and then slowly, as you feel more comfortable, go lower down. They're definitely the most challenging corpectomies for sure.
And for XLIFs, for standard far lateral procedures, kind of a retractor time of 15 to 30 minutes has been postulated to minimize ischemia to the plexus. How does this convert into a corpectomy timing?
I would say it's probably about an hour, half an hour to an hour with corpectomies, because again, usually at L4, you're a little bit above the plexus, so you got a little bit more time. Can we disengage the cage? So you have a little bit more time, but it's still, it's still an issue. So I've had to do a lot of times where, it takes like more than an hour, and I will, you can see there, I'll leave the shim in, take the shim out, and then deflate the retractor. So we'll get one final x-ray. And one other important point, you guys, is that I've had a couple cases where, and this is, I think, I just get abdominal films as well as chest x-rays in the PACU. I've had two cases where, we had a small little pleural injury and the patient ended up getting a pneumothorax. And then it was like an L1 or T12. And because we're not, we're going behind all these structures, usually these, the visceral pleura is way far away from you, but you can sometimes catch it if you're doing L1 or L2. John had you can see the cruce, you can see all the attachments. So I've just always, I think it's a good idea to get an abdominal and chest x-ray as soon as you're done in the PACU. So.
Really good. Great. Thanks so much, guys. Thank you to Globus for their equipment, and to Zach, good job. I hope your back pain is not too tremendous. And the ergonomic aspects of this has to be considered.
Rod, can I have a question?
Yes, Bijan, Rod, stay online. Bijan has a question.
I saw your box cutter a couple of times going beyond the body. How do you control that?
Say that one more time, Bijan.
I saw a couple of times your box cutter was beyond the body.
Yeah.
How do you control?
I mean, honestly, so this is a cadaver. In real life, it, knock on wood, doesn't happen as much because, it's much harder to go through the vertebral bodies, and then it's much more controlled because we don't have all of our instruments today. But the instruments I have, I actually have like multiple osteotomes, and the osteotomes, it's very controlled. Every 2 or 3 millimeters, we're cutting across the bone. You can actually see it, and so in the cadaver, it's a little different.
Thank you.
Yeah.
Great. Okay, we'll put some concluding slides on here. Thank you, Rod. Please join us. Thank you very much for this demonstration.